Now, what you use is 1 to 2 micrograms per kg body weight of fentanyl, normally as a
Okay.
pre-medicant. But for induction, it is nearly 25 mics to 50 mics per kg body weight. That amount of dose when you give, invariably post-op respiratory depression would occur. And it used to have a prolonged duration of action. That is why this combination was specifically used in patients with cardiac surgery, wherein elective postoperative mechanical ventilation would be done in those patients. So now with the etomitate introduction, so we can use etomitate instead of this combination,
Okay,
Okay,
sir.
sir.
uh,
Yes, sir.
opiate and benzodiazepine combination.
Better.
Okay,
Yes, sir.
so let us go with propofol a little bit. We had left out. One is the pain and injection with propofol. One of the
Yes,
side
sir.
effects of propofol, it's really very bad as far as I've seen. One child that forgot to give lidocaine, and
No,
then
lidocaine.
one of our students tried to inject propofol. The child cried with pain and then withdraw the hand.
And
So
okay,
it
sir.
is so painful actually in some patients. So you have to be extremely careful. This is one of the absolute drawbacks of propofol.
Proper.
And I
Propofol.
told you the pain of injection of propofol is actually due to propofol itself,
Propofol.
not
Itself,
due to the
not
lipid emulsion. Because
yes, sir.
everyone thinks that it is because of lipid emulsion. It is
Dimension.
nothing to do with the lipid emulsion. It is mainly because of the propofol
Propofol is
active propofol molecule itself will irritate the nociceptors in the veins.
yes, sir.
So how do you prevent this pain on injection of propofol?
Sir, we can add lidocaine, sir.
So
Lidocaine,
before
ah,
injecting propofol,
For
like a Bayer's block, we can give lignocaine before 5 minutes through the vein, and
okay.
after 5 minutes we can inject propofol, sir.
2 minutes is enough. No, you need not have to wait for 5 minutes. So you use a
Okay.
rubber tourniquet,
Yes, sir.
a venous tourniquet.
Yes, sir.
yes, sir.
Or if somebody even can just apply pressure
Okay, sir.
with the hand, so that just the blockade of the venous blood is done.
Done.
Yes, sir.
And through the vein you inject usually not more than 20 milligrams of lidocaine.
Yes, sir.
20
That
milligrams,
is
yes.
more than sufficient,
Yes,
because
sir.
what this lidocaine produces is it produces anesthesia of the nociceptors in that particular part of the vein
Vein.
Yes,
Okay,
sir.
sir.
where you are injecting. Because one thing you should realize, the propofol, when it is injected in larger veins, for example, I am injecting propofol through a central vein, I need not have to give lidocaine.
Okay, sir.
Because when you are injecting through a larger vein, the pain will not occur. That is one of the methods of avoiding pain is, inject through the antecubital vein. If you have an
Okay.
antecubital vein and you've got a cannula into the antecubital vein, then there won't be much pain, because larger vein, the irritation of the nociceptors is much less.
Yes,
Okay.
sir.
Smaller veins, the nociceptor activation will be very high. So that's how, if you can avoid injecting through a smaller veins. But majority of the times we usually have our IV line either wrist or on the dorsum of the hand. These are
Awesome.
the smaller veins. So invariably you have to. Now, there are one of the methods is, as you said, it is the best method, is
Yes,
apply venous tourniquet
sir.
and then inject lidocaine, wait for 2 minutes, because 2 minutes is required for the lidocaine to
To
get
add.
onto the nociceptors in the vein, internal
Yes.
wall of the vein, and to produce its anesthetizing effect there.
Yes,
And
sir.
afterwards, you remove the venous tourniquet and inject propofol. There won't be any problem. The
Yes,
other
sir.
methods are, you can inject even fentanyl.
Continue.
Yes,
Okay.
sir.
And then inject, the amount of pain is much less. And
Yes.
even people have tried, serotonin antagonists, like 5-hydroxytryptamine 3 antagonists, like, your ondansetron,
Done, done, sir.
and all those things. They have tried that also. That also has produced a decreased amount of pain. But best is injecting lidocaine. That is the, gold standard for prevention of pain on injection. But some
Yes.
people also combine
But
propofol with the lidocaine in the same syringe and inject. Do you think
That's how we do here, sir.
No, that is actually
Ram.
good practice.
Yeah.
Oh, this.
Because it is said that it separates the lipid emulsion from propofol, it seems, when you add lidocaine, and these produces small vesicles,
Vacuums.
lipid
Vacuoles.
vesicles, and they can produce some amount of thromboembolism,
Tom members.
Yes,
Yes, sir.
especially pulmonary, smaller vessels in the lungs, they can block. That is what in one of the books that is given. So that practice may not be ideal, and you are not giving enough time for lidocaine to produce its effect
Effective.
when you are combining propofol and lidocaine in the same syringe and then injecting, isn't it? So that way, ideal method is what I always teach and we practice is somebody holds, apply pressure
Sure. Okay.
proximal to the vein, and then you inject lidocaine, wait for 2 minutes, and then you inject the remaining part of or whatever the propofol that is there. One
Yes, yes.
other thing, they also say that if you use small dose of propofol first and wait for 2 to 3 minutes, say about 5 milligrams of propofol, half ml, that also has been tried. That also
Okay.
produces some amount of,
And I'm
decreased pain after injection of propofol. So, but best is probably lidocaine. So that is one thing. So there is, power has gone in your place or what? No power? Hello, lost your communication, I think. Mahal? Mahal, lost you. So, yeah, or direct from your phone you can connect. Okay, okay. Right, 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 right. So now, I think other people are also there, like Shilpa, I can see Nitin is there. So many of you are there, Charan. So do you have any doubts regarding whatever we discussed yesterday till we get a connection from Balaji and I think you can definitely participate. You can just talk if you have any doubts on anything. It need not be whatever we discussed on IV anesthetic agents. Whatever the doubts you have regarding anesthesia, you can just briefly discuss till we have Mahal and Balaji to come back. I think audio will be there. I think you can ask me. Hello. Ah, Mahal. So still you're not very clear, I think. Not able to hear.
Sir,
now it is fine, sir.
And now I can hear, but your image is not very good. Anyway, you got from the university, is it, or Department of Anesthesia, or you got back the internet?
No, sir, there's a power shutdown, sir, here in our
Oh,
place, sir. So,
okay.
and the network is also just wavery, sir. It has gone shut down, sir. Something has happened, sir.
No, that's what I
Now,
was trying to tell you, that why can't you use your mobile internet?
no, sir, now we are using the mobile
Mobile
internet
internet, sir.
only, sir.
Mobile internet. Okay.
Yes,
Yes,
Okay.
sir.
sir.
Is it okay? It's good.
Yes, sir.
Okay.
It's
As
now
long
okay,
as
sir.
I think even about 15, 20 Mbps also is fine.
Yes,
Actually,
sir.
that is enough for Zoom meetings, actually.
Sir.
So anyway, you have to delete all these things when you want to upload these things to YouTube.
Yes,
So
sir.
Sir.
you have to edit all this.
Yes, sir.
Yes, sir.
Okay, okay. So we'll just,
Sir, can you able to see us, sir? Or it's just blur, sir?
yes,
Is it clear
slightly
now, sir?
not very clear. Your images are not very clear. I think you can take out that background thing, because that is the one which is producing some problems.
Sir, yes, sir. 1 second, sir. We'll
Let
just
it be
remove it.
your, you can blur the background. There is an option there to blur the background. You can just blur it. That is what I have done.
Okay, sir.
Yes, sir.
Okay, sir.
So background will not be visible. It is totally blurred.
Yes,
Okay.
sir.
You go to that option of in the Zoom itself
Yes, sir.
regarding the backgrounds.
Yeah.
Or otherwise, okay, we'll just continue. No problem.
Yes, sir. Okay, sir.
No, actually, it's okay. Your images are fine.
Okay, sir.
Okay, sir.
Okay. So we were talking about propofol and pain and injection, I think.
Yes, sir.
Yes, sir.
So these are the things which you have to do using a larger vein for injection. Second thing is, applying venous tourniquet and using lidocaine first and then injecting propofol later. That is the best option. Other drugs like midazolam, fentanyl, pre-medication also will decrease. And
Yes, sir.
drugs like 5-hydroxytryptamine 3 antagonists like ondansetron, ramosetron, palnosetron, if you have injected earlier, and that also will decrease the pain.
Yes, sir.
Okay, that is one of the things which we did not discuss yesterday, so wanted to discuss today.
Yes, sir.
And another thing
Okay.
yesterday, the feeling of well-being, it is mainly because of the increase in dopamine in nucleus accumbens.
Okay, yes, sir.
Accumbens, that is the nucleus accumbens. That nucleus
Yes.
accumbens in the brain, there is increase in the dopamine concentration that produces a feeling of well-being. That is the one which produces, addiction liability with propofol. So that is another thing. One more thing we did not discuss about propofol advantages, the uses, is it also has got an antipruritic effect, especially
Yes, sir.
opioid induced. For example, if you have used an opioid, intrathecal opioid, invariably it produces pruritus. So in such situation, even if you give just 10 milligrams propofol IV, so almost nearly 30 to 60 minutes, the antipruritic effect will be there.
Okay.
Okay, sir.
So just 10 milligrams, just as much as what we give for anti-emetic effect is also 10 milligrams. IV propofol is more than sufficient to produce 2
Sufficient.
hours of
Yes,
anti-emetic effect, especially the post-operative nausea and vomiting.
yes,
So
sir.
Yes,
these
sir.
are, for some of the few things which we did not discuss. So I just wanted to add to our discussion regarding the propofol of yesterday. So now we'll go into anything else, any doubts regarding propofol, so that we can go to thiopental sodium or barbiturates. Anything else you want to know about propofol? Even we discussed
Sir,
about
sir, during the time of induction, no, sir.
Ah.
During the time of induction, at what rate, sir, at what speed we should give the propofol, sir? Sometimes we
no,
inject the propofol at fast
Now, one thing you should realize that all IV induction agents should be injected slowly. There is something called as a bolus effect with occur. Bolus effect. Bolus dose is different. Bolus effect is,
Bolus effect.
you should always understand.
Yes,
When
sir.
you give any drug faster, whatever it may be, I'm not talking about the propofol or Thiopental or whatever it may be. So any drug, when you give fast, rapidly, what will happen is there is no time for the drug to get diluted in plasma. So a high concentrated dose will directly go to the effector site and it can produce a very high effect. Like for example, now let us say that the therapeutic concentration of propofol is 2 to 5 micrograms per ml is the therapeutic concentration.
Yes, sir.
When you give rapidly, the concentration at the effector site can become more than 100 to 200 micrograms suddenly. And not only in the affected site, it also can affect the other sites, vessel-rich groups like heart. And there can be severe hypotension, myocardial depression, and even collapse of the patient. That is why all drugs, I always tell all my postgraduates, every drug, whatever may be the drug, you whether it is atropine, glycopyrrolate, or whatever it may be, you inject very slowly. The only
Yes, sir.
two drugs which you have to inject very rapidly. One drug is succinylcholine.
Saxa.
Yeah, because succinylcholine rapidly gets metabolized in the plasma by pseudocholinesterase or
Cholinesterase.
ketocholinesterase
Yes, sir.
or pseudocholinesterase. So rapidly gets, actually, when you inject succinylcholine rapidly, only 10% of the drug will reach the neuromuscular junction.
Yes, sir.
That means 90% of the drug gets metabolized within the plasma.
Plasma.
When
Okay,
you
sir.
inject very slowly, 100% of the drug gets metabolized in the plasma and nothing will go to the neuromuscular junction and it will not act at all. That is why
Okay.
succinylcholine is one drug where you have to inject very rapidly. The other
Yes,
drug
sir.
you have to inject rapidly is adenosine.
Okay.
Adenosine also gets metabolized within the plasma by non-pseudocholinesterase esterases.
Yes,
So
sir.
that is why if you inject adenosine very slowly, so it will not be effective at all. So barring these two drugs, all the other drugs you have to inject very slowly.
Okay, sir.
So of course, whenever there is a local anesthetic systemic toxicity, again, lipid emulsion also you'll have to inject rapidly.
Yes, sir.
Okay, sir.
Lipid emulsion is one of the treatments, 20% lipid emulsion, 1.5 ml per kg body weight. You inject within 1 minute, very rapidly. So all other drugs you inject very slowly. That you have to keep it in your mind. Otherwise, the bolus effect will occur. Bolus effect means high dose of the drug, high concentration of the drug without getting diluted will reach the sites where it will act vessel-rich group and it can produce a lot of side effects because the concentration will be higher than the therapeutic dose. It will be in the toxic concentration. So you give enough time for the drug to get diluted. That's why all drugs to be injected very slowly. Even many times this confusion will occur in rapid sequence induction.
Yes, sir.
Because you think that in rapid sequence induction, the induction agent has to be injected fast. No.
Fast.
Rapid sequence induction means what? Rapidly you get into the airway, separate the airway from GI tract.
Yes,
Yes,
That
sir.
is what is called as rapid sequence induction.
Induction.
There also you have to inject induction agents, you inject slowly. Succinylcholine, you inject fast.
Fast.
Wait
Yes,
for
sir.
1 minute. In the meantime, apply cricard pressure. Then, do the laryngoscopy, intubate, inflate the cuff. Now somebody can take out assistant can take out the fingers from the cricard cartilage.
Yes,
So
sir.
that is what is rapid sequence induction. And even in rapid sequence induction, the injection of the induction agent, whether it is Thiopental, propofol, etomidate, or ketamine, all these drugs have to be injected slowly only. So
Yes,
that
sir.
you should always realize. Injection is always, administration of the drug is slow only. Okay. So that is what is very important. And now let us move on to any other doubts
Sir,
regarding propofol?
No, sir.
so maybe anyone else will just check it out, sir. Anyone
Because
else?
when you were not in contact with me, I was asking them
Okay,
Okay,
sir.
sir.
to come out and nobody responded actually. I don't know. They could have responded. I think they could have spoken, isn't it? So
Yes, sir.
maybe they all have understood everything. They have not understood anything. That is all or none.
Yes, sir.
I hope they have all understood whatever we have discussed yesterday and whatever the brief period we have discussed today. So coming to the other very important, the first IV anesthetic agent that was introduced, thiopentone sodium or
Thiopental.
barbiturates. Yeah, barbiturates. Will start with barbiturates.
Yes, sir.
Yes, sir.
So one is that how often you are using thiopentone sodium? In your
We'll be using
Sir,
in ECT,
ECT
sir.
we use it, sir.
ECT you will be using, but ECT it is not the drug of choice.
Sir, it's methoxytol, sir.
Methoxytol
Methoxytol
is
is
the
the
Ideal
gold
will be the
standard.
methoxytone in
Methoxytol.
right? Because
Yes.
thiopentone sodium suppresses the seizure focus.
Yes,
Seizure
yes,
focus.
sir.
So the dose of electricity that is required to produce an effect of that convulsive effect will be much higher.
Yeah, yes,
Yes,
That
sir.
is why thiopentone is not a drug of choice. Etomidate is fine.
fine, sir.
Either methoxytone or etomidate. These two are the drugs which can be used for ECT. Anyway,
sir.
Yes, sir.
in many times pediatric patients you may be using, because in JSS hospital they use our postgraduates and other consultant use thiopentone more often in pediatric patients.
Okay.
Anyway, till about maybe about 10-15 years, thiopentone was the most commonly used IV injection agent.
Yes, sir.
As far as I remember, for a long time I used to use thiopentone as the induction agent because propofol was not available in India.
Yes, sir.
Propofol was made available in India only after about 2005 or 2006.
Okay,
After
sir.
that only it was made available. Till then it was not available. So you can imagine we were using only thiopentone. So anyway, we'll just discuss these barbiturate derivative. Thiopentone is a barbituric acid
Yes.
derivative, isn't it? So
Yes, sir.
what is actually the barbituric acid?
Sir, it's urea plus malonic acid,
Yeah,
sir.
very good. So it's a combination of urea and
Urea
Mal-
plus
mal-
malonic acid.
barbituric acid, and
Acid.
we have oxybarbiturates and thiobarbiturates.
Yes,
Yes,
sir.
sir.
So what is the difference between oxybarbiturates and thiobarbiturates?
Sir, oxybarbiturates is the second position. It is replaced by oxygen, sir. And in
Okay.
thio, in second position, sulfur. It has been replaced by sulfur, sir.
Sulfur. So that's how we have two different kinds of barbiturates, oxy and thio. Oxybarbiturates, can you give some example?
Sir, oxybarbiturates, methoxytol.
Yeah, methoxytone.
Methoxytol.
Yeah, and phenobarbital,
Phenobarbital.
which
Okay.
is extensively used as an anti-epileptic agent. So methoxytone and phenobarbital. Whereas the thiobarbiturates, what we have is
Thiopental
Thiopental
sodium and thiomylals.
thiamylal. So these are the two things which we use. And one thing again they'll be asking you is the structure of thiopentone sodium. Can you just describe the structure of thiopentone sodium? Chemical form like
Sir,
diisopropyl.
5-ethyl 1-methyl butyl, sir. 5-ethyl 1-methyl butyl.
Actually, it is 2-thio.
2-thiobarbituric acid, sir.
No, it is 2-thio.
Oh, okay, sir.
At fifth position, you have ethyl, methyl, butyl side chain.
Yes, sir.
It is a benzene ring.
Yes,
And
sir.
second position, you have thio, that is a
Yes.
S group, the
Yes.
sulfur. Fifth position,
It
you
does.
have the side chain. Side chain contains ethyl, methyl, butyl.
Yes, sir.
So that is why it is called as 2-thio,
Oh,
5-ethyl, methyl, butyl, barbituric acid.
Yes, sir.
So what is the importance of this structure? Which gives the lipophilicity and rapid onset of action? Which particular part of the structure gives the hypnotic effect?
Sir, the breakdown of the barbituric acid
No.
structure.
So you have the structure. The
Yeah,
structure
benzene.
activity relationships we always say. Based on
sir.
structure, what is the activity? So we have at the second position, we have the sulfur atom.
Yes, sir.
Fifth position, we have the side chain.
Yes, sir.
Methyl butyl side chain is there. So we have, it is rapidly acting. It is almost 50 to 70% liquid solubility it has got. And
Yes, sir.
it has got a very good hypnotic effect. It is one of the very good induction agents. So
Yes, sir.
the rapid onset of action and lipophilicity is given by which part of the structure, and hypnotic effect is given by the which part of the structure. It is commonly asked exam question. Now I'll tell you the second position, that is the thio group, that is a sulfur atom. It gives the rapid onset of action of thiopental sodium and also
Okay, sir.
gives lipophilicity of the drug.
Yes, sir.
Okay, sir.
Whereas the side chain, the longer the side chain, higher will be the hypnotic effect.
Okay,
Okay,
sir.
sir.
So the hypnotic effect is mainly because of the side chain.
Okay,
And
sir.
rapid action, onset of action is because of the sulfur atom, and the
Okay.
lipid solubility is also sulfur atom. In methohexetone, it is the oxygen atom that is present at the second position also gives rapid onset of action and also the lipid solubility. Whereas the methyl group in case of methohexetone produces its epileptogenic effect and myoclonic movements. That
Yes,
is what is because of the methyl group that is present in the side chain, that is fifth group. So these are few of the structure activity relationships you should always remember about. Now you are holding thiopentone sodium. Is
Yes,
it?
sir.
How do you describe it?
Sir, it is a yellow amorphous
Amorphous
powder.
First you tell it is a vial.
It's
Yes, sir.
it's
It
a
is a
vial.
vial, sir.
You always describe, you start with this is a vial containing or this is an ampule containing like. So this is a
Sir.
vial containing.
Sir, it's a vial
While containing
containing
500 mg of thiopentone sodium, sir,
Yeah,
in a
it
powder.
comes as 500 milligrams and 1 gram.
1
Yes,
gram.
sir.
So it comes in two concentrations, 1 gram vial and also 500 milligrams vial. So what is the powder, color of the powder? Is it white
Yellow,
or
It's a
sir.
yellow
Yellow
amorphous
amorphous
powder, sir.
yeah, yellowish, lemon yellow powder?
Lemon,
sir.
yes, sir.
Is lemon yellowish powder,
Yes, sir.
and it has to be reconstituted
Yes, sir.
to use, isn't it? So with what you reconstitute?
Sir, normal, sir.
Normal saline and 5% dextrose.
Okay, how about ringer lactate?
We
We
shouldn't
should not,
mix
sir,
it.
because it is acidic, sir.
This is alkaline.
This is alkaline. It is highly alkaline, sir. The
No,
pH is
but
around 10.5.
no, why it is alkaline? It is actually barbituric acid derivative. How can it be alkaline?
Sir, because of the
No, you only said it's a barbituric acid.
Barbituric
Yes, sir.
derivative, sir.
Huh. What is that sodium stands for?
Sir, it 6% anhydrous sodium carbonate, sir, which
that
makes
is
it
what-
Anhydrous sodium carbonate.
anhydrous sodium
Because
carbonate.
it has a preservative that is 6% sodium carbonate as a preservative, and this sodium carbonate makes it alkaline.
Alkaline, yes, sir.
And unless if the sodium carbonate is not there, it is not stable.
Stable,
Yes,
yes,
sir.
sir.
That is why they add sodium carbonate in order to make it more stable and to prolong its shelf life. That is the reason why its pH becomes 10.6.
Yes, sir.
So if you add ringer lactate in the ringer lactate, that reacts with thiopentone sodium and actually it precipitates.
Sir.
So you cannot use it. It becomes totally inactive.
Yes,
So
sir.
that's why you cannot use ringer lactate for diluting this. You can use 5% dextrose or you can use normal saline. Majority of the times you will be using normal saline.
Okay, sir.
So what is the concentration with which you prepare this and what is the concentration with which you administer?
Sir, 2.5.
No, when you prepare, what is the concentration you prepare?
Sir, we'll mix 10 ml of normal saline and we'll reconstitute, sir.
So if you mix 10 ml of normal saline
50
into
mg per
500
50 mg
Sir, 50
mg per cc, sir.
so what is the percentage concentration you have made?
So 5%, sir.
5%.
that
But
is
we'll
what,
again
whenever
Reconstitute into 2.5%,
Yeah.
sir.
So that you should always remember because this is one of the common exam questions that is asked because suppose you have reconstituted it.
Yes, sir.
Okay. Somebody else comes and then takes it and then loads it and then give it. So he always thinks that it has been reconstituted at 5%.
Yes, sir.
So that is a standard reconstitution
Yes, sir.
concentration that you should always remember. So you
Yes,
can't
sir.
reconstitute it to 2.5%. Then somebody will think that it is 5% and further dilutes it. It becomes 1.25%.
Percent.
Then it will not act at all.
Yes, sir.
So that is why the standard reconstitution concentration you should always remember. So it is it is made 5% reconstituted, and then when you are using it, you further reduce the concentration to 2.5%.
5%.
Why do you reduce the concentration to 2.5%? Why not 5% you inject?
Sir, it causes inflammation in the vein if it is 5%, sir.
No, no. It won't produce any problem in the vein as such. Why this was advocated since a
Sir,
long time?
sir, maybe because of it can be used for maybe a week's
No, no, no.
prolonged.
No, that is different. We will come to that, how long this
Okay, sir.
life. So it is mainly, one of the adverse problem or the problem.
Intra-arterial injection, sir.
Yeah, in the olden days, we did not have IV cannulas.
Sir,
Yes.
So we had to
glass syringes.
directly we had to put a needle into the vein and then inject.
Inject,
Yes,
yes, sir.
Accidental intra-arterial injections used to be, though not uncommon, used to occur. We'll come to that at the end when we discuss.
Yes,
Okay,
sir.
sir.
Yes, sir.
Okay, sir.
So this, if it is introduced in intra-arterial injection, if it is accidentally done, the adverse effect is much less if you are using 2.5%.
5%.
5%. Okay, sir.
So, instead of 5%, that is the reason why we use 2.5%. Why not further dilute it and then use it? Why not
Sir,
further
maybe
dilute it to 1% or?
it loses, sir. If it died to 1%, then the composition, it won't act, sir.
No, no, no. It will act because, the mass of the drug that is
Oh,
when you inject. The total mass, what you inject is more important, isn't it?
button, yes, sir.
Yeah. So, like propofol, for example, you can give direct IV bolus or you can give even as an infusion.
Yes, sir.
So it will take slightly more time to get the patient to get induced. And that is what you can do, especially when in patients who are not very stable as far as their hemodynamic status is concerned. Then you can go for a propofol infusion to induce. Go for 300 to 500 micrograms per minute, infusion. So within 3 to 4 minutes, the patient can get, induced. So 300 micrograms per kg body weight infusion. So he can get induced. So, but the induction takes slightly more time. So the hemodynamic effects will be much less.
Yes, okay, sir.
So that is what you can do. But here also that can be done. But one thing what they have realized is if it is diluted further and injected, there is more hemolysis it can produce.
Okay, sir.
So these are all the exam questions. You will not find it in many of the standard books.
Yes,
Textbook,
sir.
yes, sir. We didn't find this one.
Fine, sir.
So unless you read older books, so
Okay.
you may not find it. So that is why the standard administration concentration is 2.5%. Standard reconstitution concentration is 5%.
5%.
5%.
Always realize. And the other common question we'll be asking you is, now there is a powder is there in your vial.
Yes, sir.
Above the powder, what is there? Is it air or something else?
Nitrogen, sir. Nitrogen.
Yeah, why nitrogen will be there?
Sir, to prevent precipitation, sir.
Why it can precipitate? What in the air it reacts with and produce a precipitation? Is there any acid in the air?
Sir,
Is there any acid in the air?
Atmospheric.
carbon dioxide.
Carbon
CO,
dioxide is a volatile
carbon
acid.
dioxide.
Carbon dioxide is a volatile acid, isn't it?
Yes, sir.
Yes, sir.
So carbon dioxide, though small concentration of maybe 0.2 or 0.3% of carbon dioxide is there in the air. So, but if air is there above the powder of thiopentone, it reacts with thiopentone, it crystallizes and produces, precipitation. So shelf life will be very, very minimal. Even without reconstitution, there will be precipitation. That is why this is a standard question that is commonly asked. What is present above the thiopentone powder? It is an inert gas like nitrogen, which cannot react with thiopentone powder, and shelf life can increase. So now another question is, so once you have reconstituted, how long you can use Thiopental? Like we were discussing about
2
propofol,
weeks.
more than
Sir.
6 hours.
Sir, we can use it till 1 week, sir.
Up
1
to
week
2 weeks.
after?
Sir, 1
After
week.
5% dilution, sir.
No, you have to refrigerate it.
Refrigerator, sir.
Doesn't matter 2.5% or 5%. After reconstitution, you have to keep it in the refrigerator.
Refrigeration.
So after refrigeration, it can be the shelf life, it won't precipitate for nearly 5 days, 7 days to 10 days. So you can reuse it. But without refrigeration, how long you can?
5 days, sir.
2 days,
2
48
days. 2 days.
Because many times we used to see in our olden days, our PGs used to keep they used to reconstitute on Saturday, keep it there. And by the time we come on Monday, there used to be precipitation. We had to throw it off. So they used to forget and then keep it over our anesthesia machine itself. Majority of the times, that is what everyone does, isn't it? So that is another very important thing you should remember. Then what about the drug interaction when you are injecting? Is there any drug interaction that is very important with Thiopental when you want to inject?
Sir, we should not give acidic drugs, sir.
Like, can you give examples?
Sir,
What are the common-
attract,
Vecuronium, sir.
Vecurium, atracurium, dopamine, dobutamine.
all muscle relaxants.
Relaxants.
Why this is very common is normally when you want to induce, so you induce with Thiopental and afterwards you'll be using a muscle relaxant through the same vein, isn't it? You'll be
Yes, sir.
using either succinylcholine or a non-depolarizing muscle relaxant.
Yes.
What they do is, for example, now you have not flushed the IV cannula, which contains Thiopental. Now you try to inject either succinylcholine or atracurium or vecuronium or whatever non-depolarizer. The whole thing, there will be precipitation within the cannula. There will be total obstruction of the cannula.
Yes, sir.
So you cannot inject anything afterwards.
Yes, sir.
And your drug of your succinylcholine and non-depolarized will not be effective at all. They would not have gone further. That is why this is another very important practical question that will be asked for you. So after you give Thiopental sodium, you have to flush the vein.
Yes, sir.
And then only you have to inject. Because the cannula you have to flush, because through the cannula IV fluid is going. But there are two channels. Through one channel, the fluid is going. When you inject from the port, there is a separate channel is there for you to inject. So that particular channel gets blocked.
Yes.
So that is why it is very important that you flush separately. With normal saline, you take about 5 to 10 ml, you just flush it and then you have to use it. So this is what is very important regarding its interactions with acidic drugs. Okay. Now, coming to the the mechanism of action of Thiopental sodium. So before that, brief history about Thiopental. Yesterday we discussed when it was introduced.
Sir, actually, first barbiturate was hexabarbital, sir.
Okay. No, but Thiopental we're asking.
Sir, 1934, sir, by Lundy and Waters, sir.
Lundy and Waters,
sir.
Introduced. And any historical,
Sir, Pearl Harbor tragedy, which happened in 1944.
1941.
7th December 1941, sir.
So what is that Pearl Harbor tragedy?
Sir, it's that for to relieve the pain, sir, they injected Thiopental without the dosage. They didn't know the approximate dosage, and they were putting on all the war people, sir. Those who were affected.
No,
sir.
Pearl Harbor means, you should know that, America was not involved in the Second World War till 1941. When Japanese bombarded the air base, which was there in the Pearl Harbor. So then, America was forced to enter into the Second World War. So when this Pearl Harbor air base was attacked by Japanese, there were a lot of casualties. And these casualties, when they were brought to the hospital, they were really hypovolemic because they had bled a lot, multiple trauma, bled a lot, hypovolemic. These people who were, trying to anesthetize these patients, many of them were non-anesthesiologists during that time. And when they were using, thought that they can use thiopental like inhalation anesthesia like ether.
Ether.
Okay, sir.
Obviously, they could think that boluses of thiopental they could use, and infusion of thiopental they could use to anesthetize these patients, because they did not know about the cardiodepressive effects of thiopental,
Effects.
especially in hypovolemic patients.
Yes, sir.
So that is what it is said, that there are a lot of people died because of
Okay, sir.
thiopental. And the next day in the newspapers in New York Times, Washington Post and all, there was a big news in the front line of the paper that thiopental killed more number of patients than the bombs of
Bomb.
Japan.
Yes, sir.
And somebody called Beecher, I think he wrote an article on thiopental sodium, and he wrote that it is an ideal drug for euthanasia. So because it could kill. That is what, because they did not know about the pharmacodynamics and pharmacokinetics of thiopental much, because it was recently introduced into anesthesia, and there were not qualified people who could use thiopental sodium. That was the reason why so many casualties occurred. Of course, there was a later in 1994, one more paper was brought out regarding the casualties. It said that there were not many casualties as such. It was unnecessarily exaggerated. So that's what, in 1994, again in America, they brought out these papers. It was, but whatever it may be, that Pearl Harbor is always associated with thiopental sodium. So you should know, because you may be asked such questions. If you're answering very well, such questions will be asked. So that you should always remember. And in 1955, actually, Dundee, another person you should always remember regarding thiopental sodium. So he wrote a book also on IV anesthetic agents in 1955. He studied extensively thiopental, and he brought out that thiopental should not be used in, or should be very carefully used in patients who are having hypovolemia. It can produce cardiac arrest on table. So that's how he realized that that was the reason probably why many of these casualties died with Pearl Harbor, casualties. So that is what is one more thing you should always remember about thiopental sodium. So next is, I was telling you, next you talk about the mechanism of action of these. So how do they act?
Sir, it acts on GABA A receptor, sir.
Yeah, same way like
propofol.
Sir.
Yeah, there is a separate barbituric acid subunit on the GABA receptor complex.
Yes, sir.
It will act on the GABA A receptor complex, and also it produces both types of effect.
Yes, sir.
Is what is yesterday we discussed?
Sir, at high concentration and low concentration, sir.
GABA facilitating
and GABA mimicking, sir.
Mimicking,
yes, sir.
GABA mimetic. So GABA facilitatory or potentiating the GABA effect is by the regular dose of induction dose.
Yes, sir.
Higher doses, if you are giving, then it can produce GABA mimetic effect.
Mimetic, sir.
Mainly on the gamma aminobutyric acid receptor complex. Again, the opens up the chloride channel for a sustained period and produces inhibition of transmission of synapses and produces hyperpolarization. Produces hypnosis. That is how it will be acting. And the next is, it's metabolism and or pharmacokinetics.
Yes, sir.
Where does it gets metabolized?
Sir, it is metabolized in the liver, sir.
Okay.
Hepatic metabolism happens, sir.
Okay.
So this hepatic metabolism, what will happen? It triggers the ALS.
No, it actually an enzyme inducer.
Enzyme inducer.
So all barbiturates are enzyme inducers. Thiopental sodium gets metabolized in the liver.
Yes, sir.
It gets what are the metabolic end products? How does it get metabolized?
Sir, oxidation, oxidation, dealkalization, breakdown of barbituric acid rings, and desulfuration, sir.
Yeah, as you said, you are correct. So one is ring cleavage. Whatever the benzene is there, it
Yes,
cleaves.
sir.
That is one thing. Second thing is desulfuration. Sulfur is removed from the benzene ring, and N-dealkylation also will occur.
Yes, sir.
And plus,
Oxidation.
oxidation of the side chain.
Side chain. Yes.
There is a side chain because 2-thio-5-ethyl methyl butyl. So the desulfuration, the sulfur atom is removed, the side chain is removed, the ring is cleaved.
Yes, sir.
Whatever the benzene ring is cleaved, and dealkylation also occur. What are the metabolic end products?
For hydroxythiopentones, sir. Metabolized to hydroxythiopenton and carboxylic acid derivatives, sir.
Carboxylic acid, pentobarbital.
Yes, sir.
Pentobarbital, carboxylic acid, and urea.
Yes, sir.
Yes, sir.
Urea, barbituric acid is a combination of malonic acid and urea. So,
Uric acid.
urea, pentobarbital, carboxylic acid,
Acid.
these are the metabolites, and these are metabolites are non-active metabolites.
Yes.
Okay. So now another very important thing is in pharmacokinetics. So how the effect of thiopental will go off and the patient becomes awake.
Sir, 2 to 8 minutes, sir.
Around 15 minutes, 10 to 15
it's
minutes.
about 5 minutes, 5 to 15
minutes.
minutes, slightly longer than propofol.
Propofol,
Okay,
yes, sir.
About 5 to 8, because propofol is 3 to 5 minutes, and
Yes,
thiopental is 5 to 8 minutes.
5 to 8 minutes.
Why? How the patient will come out of the hypnotic effect?
Sir,
Again,
redistribution.
discussed.
Redistribution will happen,
again,
sir.
redistribution away from the effector site.
Effect side,
Yes,
yes, sir.
Into the muscles. So that's why it has been described as alpha redistribution and beta elimination.
Elimination. Yes,
And
sir.
again, in alpha, you have alpha 1 and alpha 2 redistribution,
Yes, sir.
and beta 1 and beta 2
Yes,
as far as elimination is concerned. So
Yes, sir.
alpha 1 is redistribution into vessel-rich groups. That
Yes,
is
sir.
what starts acting. And alpha 2 is redistribution into muscles and then
Yes.
into vessel poor group.
Poor
Poor
rich
group.
group.
Yes, sir.
Yes.
And beta 1 is metabolism, and beta 2 is elimination.
Yes, sir.
So that's how you should always remember about the metabolism of thiopental sodium. And what is the difference between thiopental and propofol as far as the context sensitive half time is concerned?
Sir, thiopental has a better
Increased
contact sensitivity.
Prolonged, you mean?
Prolonged.
Yes, sir.
Yeah, it has got a prolonged context sensitive half time and it accumulates.
Yes,
sir.
sir.
Unlike propofol has got, yesterday we discussed short context sensitive half time. So, propofol, you can use it as an infusion.
Yes, sir.
Yes, sir.
Maintenance of anesthesia for sedation homes.
Yes, sir.
Can we use thiopental on repeat bolus doses or also as an infusion?
Sir, repeat bolus doses every 5 to 10 minutes, sir.
No. Can we use like propofol?
No, sir.
We should not use bolus doses of thiopental, or we should not use it as an infusion for maintenance of anesthesia, because it will accumulate, it will produce a prolonged duration of action.
Action.
Patient may not come out, and especially its effect on the respiratory center produces apnea for a long
period of time.
Respiratory depression. That is what I just want to tell you about one of the experiences of one of our students who had passed his anesthesia and was practicing. So long back, this is when we had only thiopental was the induction agent. So he had to anesthetize two brothers, young children, brothers, for tonsillectomy. Both were posted for tonsillectomy in one of the nursing homes. So 6 o'clock, younger brother, it started and finished in about 45 minutes. And he could extubate the child. And, the child was sent for post-op care. The second child, the surgery started. Surgery was over. But usually after tonsillectomy, you all do again laryngoscopy for extubation, and you see whether there is any bleeding.
Bleeding, yes, sir.
So unfortunately, he had reversed the patient, and then he was trying to look for bleeding, and there was bleeding. So he informed the surgeon that there is bleeding and you have to do the hemostasis. Usually what the surgeons will tell you, they'll tell you, just give me 2 minutes or 5 minutes, I'll finish off.
Yes, yes, sir.
You all must have. And you
Yes,
know,
sir.
Yes, sir.
2 minutes and 5 minutes of surgeons.
That's
You have to
20
add
to
one more
30
zero.
minutes.
One more zero.
Yes, sir. Yes, sir.
Invariably, this happened because, you know, patient had already coming out. And what our, anesthetist did, my student actually, so he started giving repeat doses of Thiopental. So because, you know, it got prolonged, he must have used 5-6 doses of Thiopental. And afterwards, you know, the child was not coming out. The surgeon said that, okay, everything is fine, and now you can extubate. So what if there is a question of extubation? The child is not breathing. And, this actually happened around 8 o'clock morning. The outside, the younger child was eating ice cream. This child is unconscious. And, during those days, there was no mechanical ventilation. Everything you have to do manual ventilation.
Yeah,
only. Mechanical ventilator with your anesthesia, all older anesthesia machines like Boyle's Mark III or even Boyle's Basic. So he had to keep on ventilating. So by the, everybody was very anxious. The parents were very anxious. What is happening? And the child, started breathing around 6 o'clock in the evening. And he could extubate only around 7 o'clock. The child completely became all right. But in that 12 hours, nobody was there to help him. He had to ventilate continuously.
Continuously
Hand
hand
ventilation.
ventilation.
Okay.
Hand ventilation. People used to peep inside, used to be alone with the patient. That used to be very common, even with choline apneas during those days, very common.
Okay.
So, you can imagine the amount of stress the anesthetist will have. So why I told you is, Thiopental, you do not use repeat doses,
Repeated dose.
Okay, sir.
or you do not use as an infusion.
Infusion.
Okay.
Infusion you can use as only for, it can be used for as a protection for the brain in
Brain
traumatic brain injuries.
injury.
Yes,
Yes,
sir.
sir.
In that, an infusion is used. Otherwise, you cannot use because it accumulates. It goes to the muscle group and again fat group accumulates, and continuously it will be getting released into the blood,
Blood, yes, sir.
and it will be going to the brain and it will be acting on the brain. So because of this cumulative effect, so that is one of the difference between Thiopental sodium and propofol. You should always realize this. Okay. So now that is one of the important things about the pharmacokinetics. So coming to the pharmacodynamics
Yes,
of
sir.
Thiopental sodium. So its effect on various systems of the body. So
Yes,
can
sir.
you just tell about its effect on the brain? Now CNS.
Sir, it decreases CMRO2, sir.
Okay.
Cerebral blood flow, sir.
Huh.
And it decreases ICP and IOP, sir.
No, don't combine IOP with
ICP, sir. It
ICP,
decreases
yes,
ICP, sir.
Yeah, ICP decreases. What about cerebral perfusion pressure? Because
Sir,
yesterday
cerebral perfusion pressure is unchanged in
main,
sir.
you mean cerebral perfusion pressure is maintained,
Yes.
Maintained, yes, sir.
or because why it is maintained? Why propofol does not maintain cerebral perfusion pressure?
Sir,
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 MAP is very much decreased in propofol, sir.
sir.
Correct. So with Thiopental, the MAP decrease is much less one. Second thing is, the intracranial pressure reduction is much less with the Thiopental. Reduction will be more.
Yes.
And, the second advantage is MAP is not much decreased. So decrease in ICP because, cerebral perfusion pressure is nothing but, MAP minus,
minus ICP, sir.
isn't it? So that's how it maintains. So that's how, it is a cerebral protective agent. That's
Yes,
how.
sir.
So that's how, it is one of the drugs that is used for cerebral protection.
Yes, sir.
So that is okay. So what else is the effect on the CNS? Other than reduction in CMRO2, reduction in ICP, reduction in cerebral blood flow.
It has an anti-epileptic action, sir.
Very good. So it has got an anti-epileptic effect also. So what is the dose that is required for anti-epileptic effect?
Sir, 3 to
2 to 3
2 to
mg per kg, sir.
1 milligram per kg.
Okay, sir.
Just 1 milligram per kg body weight is enough to produce anti-epileptic effect.
Yes,
So
sir.
that is another very important thing you should always realize. It also has got an anti-epileptic effect. It
Yes, sir.
produces hypnosis. One more thing is it also scavenges the free radicals from the
Okay,
brain, from the injured area. Because in a traumatic brain injury, in the injured area, a lot of free radicals are released, and these
Yes,
free
sir.
radicals can damage the other parts of the brain in traumatic brain injury. So this scavenges the free radicals from there into the blood, and so that they can be removed from that area. So the further damage can be, secondary damage is reduced. So that's how, Thiopental sodium can protect the brain in traumatic brain injuries. So that is how, it's one of the drugs that can be used in TBI patients. Okay, so these are the important, effects on the CNS, which are very, very
Yes, sir.
important. But it is not much used for cerebral protection effect. Why it's not so much commonly used?
Sir, it doesn't reduce the basal metabolic.
Sir, in EEG, it suppresses burst suppression, sir.
No, that is required, isn't it? So burst suppression is the one which helps in reducing the CMR2.
Yes, sir.
What do you mean by burst suppression? What do you mean by
Sir,
burst?
EEG waves higher oxygen consumption during burst.
No, there won't be. So burst suppression means intermittently the EEG will be very flat,
Yes, sir.
and some amount of activity will be there. So intermittent activity with flat EEG is called as the burst suppression.
Burst
Burst
suppression.
suppression. Yes, sir.
So one thing you should realize, the oxygen requirement for these neurons is actually because of two things. One is the activity of the brain itself, activity of the neurons itself. Second thing is, it is for the maintenance of the the cells.
Yes.
So that is the other oxygen requirement for maintaining the maintenance of the integrity of the neurons. So when you give Thiopental sodium, it is only the metabolic activity of the brain is decreased, not the oxygen requirements for the integrity of the neuronal integrity. Whatever the oxygen is required, that will not be decreased by Thiopental.
Okay, sir.
So that's how which one actually decreases the oxygen requirement for cellular integrity of the brain. What decreases? That's how it is always, many times, it is the one which is used in all traumatic brain injury patients nowadays.
Mannitol.
No. Hypothermia.
Sir, hypothermia, because in ICU patients, basal metabolic rate, it increases.
No. In traumatic brain injury, I told you, oxygen requirement is for two things. One is metabolic activity of the brain. Whenever any activity is done by the brain, so oxygen is required. Second thing is for maintenance of the cells itself, cellular integrity.
Yes,
So the cellular integrity, oxygen requirement can be reduced by hypothermia.
Yes, sir.
So that is how, mild hypothermia always helps. That's why in many of these traumatic brain injury patients, or even in
Comatose.
post-cardiac arrest patients, so usually the temperature is reduced to 32 or 33 degrees centigrade, body temperature.
Yes, sir.
So if you combine Thiopental sodium and hypothermia, that is going to help a lot for these traumatic brain injury patients.
Yes,
That's
sir.
why any, famous personality in whom combination of these two was used for when he developed a traumatic brain injury. He's a car racer.
Sir, Michael Schumacher, sir.
Yeah, Michael Schumacher. So Mahal remembers about these people. Michael Jackson only yesterday he said. So Shoemaker. So when he
Mm.
he never had any traumatic brain injury during his car racing.
I see. Yes,
So why
sir.
did he have a brain injury?
Sir, he went for a skating, sir.
Skiing.
Skiing, sir. Yes, sir.
Skiing. So during skiing, so he fell and then had a head injury and he went in for coma because of traumatic brain injury. He was maintained on the Thiopental sodium continuous infusion along with hypothermia was maintained. And I think he must be still living.
Yes,
Well,
sir. He is still living, sir.
yeah, he is in Switzerland, I think.
Yes,
So,
sir.
so that is what you should always remember. So just remember about Michael Shoemaker. So
Yes,
then
sir.
you remember about how protection of the brain can be done by a combination of barbiturates and hypothermia.
Hypothermia.
Yes, sir.
Barbiturate coma, we say barbiturate.
Coma.
So it will only bring the EEG to flatter levels, and afterwards the oxygen requirement for cellular integrity is reduced by temperature reduction, hypothermia. So
Yes.
these things you should always. So these are all the effects of Thiopental on the brain. Okay, CNS effects. So then coming to the effects on the cardiovascular system.
Sir, CVS, it acts as central and peripheral, sir.
Okay.
In central, it causes peripheral pooling and causes a decrease in CO, sir. Cardiac output, sir.
Now, what makes actually the peripheral pooling of blood?
Sir, central sympatholic.
No, because yesterday we were discussing
Peripheral vasodilation, sir.
vasodilation means which arterial dilatation or venodilatation?
Sir, venodilatation, sir.
Like propofol. The differences sometimes they'll ask you. They'll give you propofol and Thiopental and ask you to compare.
Yes, sir.
Okay, sir.
So propofol produces dilatation of both arterioles and the venules.
Yes, sir.
So it decreases the afterload quite a bit and also the preload quite a bit.
Yes, sir.
Whereas propofol, so Thiopental decreases the preload, that is venodilatation. It produces more than decrease in the afterload.
Afterload.
Arterial dilatation, it may not produce much effect. So anyway, because the peripheral pooling of blood, so that's why venous return is decreased, so cardiac output is decreased. Plus, it also produces myocardial depression.
Depression.
Yes, sir.
But not so much as compared to propofol.
Propofol,
Yes,
yes,
sir.
sir.
So it also produces. So in normal persons, the fall in blood pressure may not be so much when compared to propofol. Propofol, even in normal persons with a normal cardiovascular system, there is going to be a fall in the blood pressure and there is also a decrease in the heart rate. Whereas with the Thiopental, the myocardial depression is much less and there is not much reduction in the afterload and there is only reduction in the or producing venodilatation. So the fall of blood pressure is not so much in normal patients with normal cardiovascular system. And another advantage here is it also increases the heart rate by almost
Yes,
30
sir.
to 40% increase in the heart rate.
Heart rate,
Because
yes,
it does
sir.
not depress the.
Sir, it doesn't depress the baroreceptor, sir.
Very good. So it does not depress the baroreceptor activity like propofol.
Propofol, yes,
That's
sir.
how increase in heart rate will just compensate for the myocardial depressant effect.
Depressant activities.
And can maintain a little bit of cardiac output so that the blood pressure fall is much less. So these are the advantages of Thiopental in normal patients. But in patients with ischemic heart disease, for example,
Yes, sir.
now, we were talking about propofol. It may be a good choice for patients with ischemic heart disease because it does not increase the heart rate. It produces actually relative bradycardia, whereas Thiopental increases the heart rate by 30 to 40%. So it can increase the supply, decrease the supply because it is a venodilator. Again, preload is decreased. So it may decrease the oxygen supply to the myocardium and also it may increase the oxygen demand.
Yes, sir.
So it may not be an ideal drug to be used in patients with
Cardiac CAD, sir.
IHD patients.
Yes,
It
yes,
is not an
ischemic
ideal
heart disease.
drug. So propofol may be a better drug.
Yes, sir.
IHD patients.
Yes.
Again, in patients with like propofol, you have to be extremely cautious to use Thiopental in patients with fixed low cardiac output status.
Poor cardiac reserve, yes, sir.
Fixed low cardiac
Fixed low cardiac. Okay, sir.
Yeah. So it may be contraindicated.
Okay, sir.
Relative contraindication is there. especially in patients with mitral stenosis, severe mitral stenosis, severe aortic stenosis, and hypovolemic conditions. Already we have discussed about Pearl
Yes,
Harbor
sir.
problem, tragedy.
Yes, sir.
And also in patients with pericarditis.
Yes, sir. So
Cardiac
dialysis, long-term
tamponade.
dialysis,
Yeah.
end-stage liver disease.
No, cardiovascular system
Sorry, sir. Sorry, sir. Yes,
Listen,
sir.
cardiovascular system we are
Yes,
talking.
sir. Yes, sir.
Yeah, of course, in end-stage renal disease, these patients.
Cardiac tamponade
Cardiac
cases.
cardiac tamponade.
Yeah. So these are the patients wherein you have to be extremely cautious in using thiopentone. If at all, if you have to use either propofol or thiopentone in such patients, you have to go for a sleep dose. Yesterday we did not discuss about the sleep dose. Will just remind me when we are
Okay, sir.
talking about how to administer thiopentone, we'll discuss about the sleep dose also. Okay,
Okay,
that's
sir.
about the cardiovascular system and thiopentone sodium. So you have to be cautious. Otherwise, in normal patients with normal cardiovascular status, you can still use thiopentone without much problem. Okay, coming to its effect on the respiratory system.
Respiratory.
Sir,
It is
dose-dependent
respiratory center depressant.
respiratory center
Depressant.
depressant, sir.
Okay, respiratory center is depressed. So one thing, and yesterday you were talking about double apnea.
Apnea, sir. Double apnea, sir. Initially,
What is
there
this?
will be
Ah,
initially there will be
the-
the apnea period of 5 seconds, sir.
okay.
Followed by normal breath, sir. Then the apnea will be prolonged for more time, sir.
Yeah, maybe about 25-30 seconds.
Seconds.
So second apnea spell can occur. So that is what is sometimes called as a double apnea.
Double apnea. Yes,
So
sir.
yesterday we discussed also, whenever you want to give thiopentone, it is very important that you have to have resuscitative equipment ready.
Yes,
Yes,
sir.
sir.
It is one of the absolute contraindications for giving thiopentone is if you don't have resuscitative equipment, because the patients can have prolonged duration of apnea. And
Yes,
many
sir.
times what happens is if the patient is stimulated, he'll breathe.
Yes,
And
sir.
if you just stop the stimulation, again the patient will lapse into apnea. Many
Yes, sir.
times it is very common. For example, if you want to use thiopentone as the sole anesthetic agent for short procedures like opening an abscess. So
Okay,
you have
sir.
thiopentone, and that too, if you have used the opioid pre-medication, this apnea can get prolonged. There can be
Prolonged.
depression. So when the surgeon produces some amount of pain, the patient will start breathing.
Okay, sir.
And it is only for a few minutes, the procedure. Afterwards, if you think that the surgery is over, you can leave the patient and then go.
Oh,
The patient will lapse into apnea. And, many times with the already use of opioids, the patient can develop into severe respiratory depression and
Depression.
even can develop severe hypoxia and hypercarbia.
apnea. Yes.
And another very important thing about thiopentone sodium and propofol and all these, they'll suppress also the hypoxia and hypercarbia, stimulus for the respiratory center.
Yes, sir.
They inhibit that, reflex stimulation of respiratory center by hypoxia and hypercarbia. So that normally, whenever there is hypoxia or hypercarbia, respiratory center gets activated, the patient will breathe more. But when you use these drugs, opioids, propofol,
Propofol, Thiopental.
yeah, this will get suppressed and the patient will not breathe. He'll lapse into a severe respiratory depression and can produce even the mortality for the patient. So that is very important. You keep observing the patient till he comes out. You resuscitate the patient, you ventilate the patient. So that's how, the effect on respiratory center becomes very important as far as thiopentone sodium is concerned. Double apnea, you have to have resuscitative equipment ready.
Yes, sir.
Okay, the next other thing is when we were discussing about propofol, we know that propofol suppresses the airway reflexes.
Airway reflex. Yes, sir.
What about
In lighter planes, it will triggers the laryngospasm and bronchospasm,
Bronchospasm,
sir.
sir.
So it sensitizes the airway reflexes in lighter planes of anesthesia.
Yes, sir.
Sensitizes, actually makes them more sensitized for any mechanical stimuli. So that means when the patient is lighter planes with thiopentone, when laryngoscopy is done, so a patient can develop laryngospasm or bronchospasm.
Bronchospasm.
So if you have already given muscle relaxants, laryngospasm will not occur. Because all laryngeal muscles are skeletal muscles or smooth muscles.
Sir,
Laryngeal muscles are skeletal muscles or smooth muscles?
skeletal.
Smooth.
It's not skeletal.
No,
So
your
skeletal,
neuromuscular blocking agents will, paralyze these
Yes.
muscles or they don't.
skeletal muscles, sir.
Skeletal
Skeletal
muscles,
muscles,
sir.
sir.
See, why I suddenly asked is, now these kind of questions will be asking you in the exam. Suddenly you don't know what to answer.
Yes, sir.
Then you start thinking whether it's a smooth muscle or skeletal muscle. They are all skeletal muscles.
Yes, sir.
So if you have already given muscle relaxant like succinylcholine, but if you are trying to now do a laryngoscopy, the patient is in lighter planes with Thiopental, he can develop bronchospasm, especially in patients with hyperreactive airway diseases.
Airway disease, yes, sir.
That is why, Thiopental is relatively contraindicated in patients.
In bronchial asthma
patients.
patients, sir.
It is not absolute contraindication, but it is a relative.
Relative contraint.
But in patients with status asthmaticus, it is an absolute contraindication.
Yes, sir.
Yes, sir.
Already, if the patient has developed a status, don't use Thiopental. Propofol is a better drug.
Yes, sir.
Because propofol suppresses the airway reflexes. Propofol is a direct bronchodilator, isn't it?
Yes, sir.
Okay, so this is one thing you should always realize. So if you want to do laryngoscopy and intubation in patients when you have given Thiopental, you should see that the patient is in deeper plane of anesthesia
Okay, sir.
when you are manipulating the larynx. That is
Yes, sir.
very, very important. You should know. One more thing is, what about its effect on the branchial smooth muscles? Does it produce bronchodilation?
Sir, no, sir. Constriction, sir.
Bronchoconstrictions.
No, it may not produce bronchoconstriction unless the upper airway is manipulated under lighter planes. Then only it can produce bronchoconstriction. By itself, it may not produce anything on the branchial smooth muscle. It is not a bronchodilator.
Okay,
sir.
sir.
So that you should always realize. So these are some of the actions of Thiopental on respiratory system. Most important thing is sensitizes the upper airways when the patient is in lighter planes, can produce laryngospasm and bronchospasm.
Yes,
And
sir.
respiratory center depression, and doesn't produce any bronchodilation, because
Okay.
you'll be asked to compare Thiopental with propofol,
Propofol, okay, sir.
respiratory effects. So that is what you should always talk about. So these are mainly, and what about its crossing the placental barrier?
Sir, pregnancy it crosses the placenta rapidly, sir, but does not contract the no
Sir, but the
action on uterus,
concentration
sir.
in the fetus will be very less, sir.
No, when it rapidly crosses the placenta, so the concentration should be same as maternal concentration.
No, sir.
But it won't have any action on uterus, sir.
Uterus, in
No, we are not
fetus, it
talking
is
about it.
Fetus.
Now, for example, if you want to give Thiopental in cesarean section,
Yes, sir.
Patient is posted for cesarean section, requires GA.
Yes, sir.
There is some contraindication for your regional anesthesia. Now you have to give GA and you have to induce. So if you give Thiopental, you said that it crosses, immediately it crosses because highly lipophilic. All these drugs, propofol, Thiopental, they all will cross.
Sir, it is a short acting, no, sir. So
So what happens is, again, it gets redistributed in
okay, sir.
fetus.
So when the fetus is born, it will immediately cry.
Yes, sir.
It will not develop any respiratory depression, or it will not develop any hypnosis, because there is a rapid redistribution also will occur in the fetus, and unless you give repeat doses. That is why we always talk about ID interval in when you give GA, induction delivery interval. If you have a prolonged induction delivery interval, all these drugs can cross the baby, cross the placenta, enter the baby, can have severe respiratory depression of the respiratory center of the baby. So that is what ID interval is. Single dose of Thiopental will not produce any problem, but repeat doses again can produce problems in the baby also. So you should not, as such, don't use repeat doses or an infusion even in the mother.
Okay.
These are some of the important things about Thiopental sodium as far as pharmacodynamics is concerned. So what are the contraindications for Thiopental sodium?
Sir, acute intermittent porphyria, sir.
We shouldn't use.
We should not give, sir.
Yeah, that is one of the absolute contraindications. Is acute intermittent porphyria.
Porphyria.
Yes, sir.
Why in acute intermittent porphyria you should not?
Sir, because the metabolite, hepatic metabolite, sir, it has alpha aminolevulinic acid, sir.
Not alpha, delta.
Sir, delta aminolevulinic acid, sir.
What it does for delta
Sir,
aminolevulinic
it
acid?
increases the porphyrin
Porphyrin
synthesis, sir. It
No,
helps in
how?
increasing.
No, what is this? Porphyrin comes in what synthesis porphyrin is always, formed? Which particular synthesis of what? Porphyrins are formed as an intermediary metabolites. In the synthesis of heme.
Heme.
Okay,
Okay.
sir. Okay.
How heme is synthesized? This is common, again, exam question for you when you are talking about Thiopental sodium. How heme is formed?
Heme is the.
Okay, if you do not know, I'll tell you.
Yes,
So
sir.
the succinyl-CoA plus glycine.
Okay, sir.
So with the influence of delta aminolevulinic acid synthetase,
Okay, sir.
forms delta aminolevulinic acid. And again, in presence of DALA synthetase, this delta aminolevulinic acid gets converted to parfobilinogen.
Okay, sir.
So for converting succinyl-CoA and glycine to parfobilinogen, delta aminolevulinic acid synthetase enzyme is very much required.
Okay.
And the parfobilinogen, afterwards, it gets converted to, uroparfobilinogen.
And strepto.
No, and coproporphyrinogen. Uroporphyrinogen, coproporphyrinogen, and protoporphyrinogen.
Protoporphyrinogen.
Yes, sir.
And protoporphyrinogen combines with iron to form heme.
Heme. Okay,
Okay,
sir.
sir.
So now succinyl-CoA plus glycine forms delta aminolevulinic acid in the presence of DALA synthetase, and DALA will get converted to parfobilinogen. Parfobilinogen gets converted to uroporphyrinogen, then to coproporphyrinogen, and to protoporphyrinogen. So that is the steps of conversion of succinyl-CoA and glycine to heme. So in these patients with porphyria, the conversion of parfobilinogen to heme, there are problems. So when you give barbiturates, including thiopentone, suddenly large amount of parfobilinogen is formed because barbiturates will stimulate or induce DALA synthetase, delta aminolevulinic acid synthetase.
Yes.
So large amount of parfobilinogen is formed suddenly, and this conversion of parfobilinogen to heme, there is a problem. It takes a longer time. So accumulation of parfobilinogen, sudden accumulation, will produce acute intermittent porphyria.
Okay, sir.
So that is why when you want to use thiopentone sodium in those patients where they are prone for acute intermittent porphyria, so thiopentone sodium and all barbiturates are contraindicated. Now you realize why.
Yes, sir.
You have understood or not understood?
Sir, understood, sir.
Oh, that is what, because it stimulates DALA synthetase,
Yes.
a large amount of parfobilinogen forms, and parfobilinogen is not getting converted further. It is taking a longer time because those steps are affected in these patients with acute intermittent porphyria. So accumulation of parfobilinogen suddenly produces all the CNS symptoms, the peripheral symptoms, passage of dark red colored urine, bronchospasm,
Yes, sir.
and hypotension and CNS effects, everything is because of the DALA synthetase stimulation and formation of parfobilinogen. So
Yes,
now
sir.
we realized. And all barbiturates, they induce the hepatic enzyme systems.
Yes,
Why
sir.
we should know, for example, a patient is on a chronic use of phenobarbital, like an epileptic patient. So why you should know that he is on a chronic use of barbiturates? What all the effects it can produce because of the enzyme induction itself.
Sir,
Metabolism of other will be rapid.
rapid.
Yeah, which requires also these hepatic enzyme systems. That will be rapid, so higher dose is required. One. Second thing is, these are the patients who are prone for halogen hepatitis.
Okay, sir.
So that we'll be discussing when we discuss regarding inhalation anesthetic agent. So halothane hepatitis is more common in these patients. You have to be more careful when the patient is on a chronic use of barbiturates, especially phenobarbital. So that is what is important about this. And what are the other contraindications of
Sir, hypovolemia, sir.
severe hypovolemia?
Hypovolemia, sir.
Severe, you should say severe.
Severe hypovolemia,
In
sir.
status asthmaticus patients.
Again, status asthmaticus, because already we said about why
Long-term dialysis patients, sir.
why
Immune
long-term
suppressive,
Immune
immunosuppressed patients.
Immunosuppressed patients, sir.
be much of an important thing. Okay. Again, in fixed cardiac output states.
Status, yes,
Yes,
sir. CAD patients with low cardiac risk.
Yeah, that is all these patients already we discussed, like severe
Yes, sir.
aortic stenosis, severe mitral stenosis. So all these patients, you should be very cautious in using. And even in elderly patients,
Yes, sir.
they'll have a myocardial depression and they can develop severe hypotension when you use Thiopental. So in all these patients, if at all, if you want to use, you have to go for a sleep dose. That's what I told you, that you remind me of sleep dose. So normally, what is the dose of induction dose for Thiopental?
3 to 5
3 to
mg
5,
per
sir.
kg, sir.
In which patients you give 3 milligrams and in which patients you give 5 milligrams?
Sir, 3 for the elderly, sir.
No, in elderly patients, you may have to even further reduce it.
Elderly, sir. For pediatric,
No,
for
it depends
pediatric
on,
patients.
one thing you should realize, well pre-medicated patients with midazolam and opioids, you go for 3 milligram per kg body weight.
Yes, sir.
If you have not pre-medicated, for example, if you just want to use only Thiopental for a very short procedure, like reduction of, fracture reduction. So then you give 5 milligram.
Higher.
Because, you want the patient to recover rapidly, fast, and then you want to discharge the patient also. So then you have to go for a higher dose when the patients are not very well pre-medicated. In children, what is the dose?
Sir, higher dose is the higher doses.
It
4
is
to
3
6.
7.
4 to 6.
4 to 6.
4 to 7.
5 to 7.
5 to 7.
Yes.
Yeah, normal it is 3 to 5. In well pre-medicated is 3 milligrams. In patients who have not been pre-medicated is 5 milligrams. In children, it is 5 to 7.
5 to 7 milligrams.
Because the distribution volume is high. So you have to give higher dose. So what do you mean by sleep dose and how do you administer sleep dose?
So 1 mg per kg is a sedative dose. So
No, how do you administer? There is nothing called as a sedative dose, isn't it? You don't use.
0.75, sir.
hypnotic.
0.75.
No, because in all these patients where you do not want myocardial depression and severe hypotension to occur, in those patients already we discussed severe hypovolemic patients, in mitral stenotic patients, in all these patients, if at all, if you want, or geriatric patients. So you have to go for a sleep dose. Sleep dose is, first you calculate the total dose that is required. For example,
sir.
well pre-medicated patient, I told you it is 3 milligram per kg body. Let us say that the patient is 60 kg patient. So your total requirement is about 180 milligrams. So half the dose, you inject half the dose. Once you inject half the dose, you wait for one arm brain circulation time.
Okay, sir.
Because normally one arm brain circulation time is 15 to 20.
15 to 20 seconds.
So in these patients where they have a decreased cardiac output, it can be higher. It can be even 25 to 30 seconds.
30 seconds. Yes,
So you wait for 25 to 30 seconds. In the meantime, you just check for the eyelash reflex.
Yes, sir.
So if it is still there, you give 25 milligrams increments.
Okay,
You
sir.
give 25 milligrams, wait for 15 to 20 seconds, check for the eyelash reflex. You give increments till eyelash reflexes are lost.
Okay, sir.
You don't give 180 milligrams total dose. You just give half the dose, then 25 milligrams increments, and wait for 15 to 20 seconds after every increment. Check for the eyelash reflex. And once the eyelash reflexes are lost, you stop. Don't inject further.
Yes, sir.
Okay, sir.
Okay, so that is what is called as sleep dose. If you want to use sleep dose of propofol, so you give half the dose very slowly first, and then 10 milligrams, increments.
Okay.
So that's how you give sleep dose, because many times in the older patients and in all those patients where they have some amount of cardiovascular instability, so you always go for sleep dose. Even in moderate mitral stenosis or aortic stenosis, if you have to use propofol or thiopentone, you always go for a sleep dose.
Okay.
So you should always remember how to give sleep dose. Now you have realized, isn't it, how to give sleep dose.
Sleep
Half
dose,
the
yes,
dose,
sir.
calculate the total dose, give half the dose slowly, then
Check
wait
for eyelash reflex.
wait for 25-30
5
seconds.
minutes and
Check
give a
for
25
eyelash reflex. Then
Yes, sir.
25 milligrams for
Yes.
thiopentone increments.
And 10 milligram for propofol, sir.
Yeah, to propofol increments. Okay, that's how you give. Okay, coming to one more, the problem with thiopentone, we were discussing intra-arterial.
Arterial injection.
Yes, sir.
So it used to be common in olden days because there were, when we were, postgraduates, and also for a long time, maybe after my postgraduate, nearly about 5 to 10 years, we did not have any IV cannulas.
Yes, sir.
No, directly you have to put an, larger 21 gauge or 18 gauge IV needle.
Needle, yes, sir.
Needle.
So it can.
And you have to fix it, and then you have to connect the IV line, infusion line, to that only.
Yes.
And the rubber part of the infusion line, we had to inject the drugs.
Yes, sir.
So you can imagine how difficult it was. And even the infusion system also, the IV lines, infusion lines were also reused. We never had any single-use IV set, infusion set, or
Okay.
even the IV fluids used to be, the fluids used to be
Glass bottles.
synthesized in the, manufactured in the hospital itself, bottles,
Okay, sir. Bottles.
Glass
Okay, sir.
bottles.
glass bottles. And these infusion lines were rubber lines. We used to boil them.
And keep and again
also
rinse.
we used to boil. And the chamber also used to be a glass chamber.
Okay.
That
Okay.
also we used to boil, connect everything, and then we used to use. So you
Yes,
can
sir.
imagine how hard way we have come up.
Oh, yes, sir.
Like you people, everything is ready and then given to use. So during those days, why I want to tell you is this, is we used to go to the fracture room, fracture reduction room. So every day we used to be posted to fracture reduction room. So there, all these close reductions used to be done by the orthopedic surgeons.
Yes, sir.
So for close reductions, we used to have one old Boyle's machine, and we used to directly inject thiopentone sodium.
Yes, sir.
So during those days, direct injection of thiopentone sodium directly into the vein was very common. So many times, either we used to use the wrist joint, this radial vein here on the radial side of the wrist, or the antecubital vein.
Yes,
Okay,
sir.
sir.
The antecubital vein, there is always the brachial artery.
Brachial artery, yes, sir.
And here the radial artery is very close by.
Yes, sir.
And that is the reason why accidental intra-arterial injections
injection.
used to occur. That is why invariably, though nowadays it's hardly seen, because you have IV cannula, and I don't think you will be putting an IV cannula into an artery.
No,
No,
sir.
sir.
Unless accidental, suppose you have got an intra-arterial line. You got an intra-arterial monitoring. For that, you have put a direct arterial line.
Yes.
Accidentally, these drugs can get injected into that.
Okay,
Very
sir.
rarely. So that is the time, nowadays, intra-arterial injection of these drugs can occur. So suppose if the, line is intra-arterial line, it has been injected. So what is the problem that can occur? What
That
problem?
can go for vasospasm, sir.
So it produces crystallization
Yeah,
and blocks the arterioles, sir.
very good. So why crystallization occur?
Sir, higher pH
No,
and
higher pH of thiopentone, 10.6. When it is injected into the blood with a pH of what?
pH of 7.3, sir.
3.5 to
7.3 or 7.4, isn't it?
Yes, sir.
So normally, you have a pH of 7.3 or 7.4 in the veins also.
Yes, sir.
There also crystallization should occur. Why it will not produce any spasm there? Why only intra-arterial injection will produce spasm?
Sir, it finally goes to the capillaries, sir.
Which one?
In intra-arterial injection.
Okay, in the veins, what happens?
In veins.
Normally, you will be injected into the vein, isn't it?
Yes,
Normally.
sir.
So what is happening there?
The crystals formed also, it will not block any vessels.
Why it
Yes,
will
sir.
not block? Very good. Why it will not?
Larger diameters.
So because it
Diameter.
keeps on increasing in the
Yes.
diameter.
Diameter. Okay, sir.
As the vein keeps on going up, the areas keeps on increasing. So the crystals are formed whether you inject into the venous blood or arterial
Or
blood.
arterial.
But the crystals are not able to block the veins because the diameter keeps on increasing.
Yes, sir.
But when you inject into an artery, now it is going to the periphery. The smaller, the diameter starts decreasing further and further. So because of that, there is a blocking of these arterioles. Once an arteriole gets blocked, there is immediately the body responds in order to push that beyond the blockage. So it tries to constrict the muscles there because
Yes, sir.
arteries contains the muscular layer. So the muscular layer will go into spasm. So because of this, there is ischemia of the limb.
Ischemia.
So because
Necrosis.
ischemia of the limb,
Gangrene.
what can gangrene of the
Gangrene can
hand,
happen.
gangrene of the hand can occur. So that is why if accidentally when you're injecting, how the patient will respond.
Sir, we'll have severe pain, sir. The initial
Yeah,
symptom will
severe
have
pain.
severe pain, sir.
So what you should do now?
Sir, we should please keep the IV in
catheter
situ,
in
The
sir.
first thing
situ, sir.
is you stop
Stop
injecting.
the drug,
Stop the
sir.
drug, sir.
Stop injecting.
Yes, sir.
As soon as the patient complains of severe pain with Thiopental, of course, propofol can produce pain. That is entirely different.
Yes, sir.
So if you use lidocaine, the patient will not have any pain. Okay, Thiopental, when you're injecting, if it is accidental intra-arterial, patient will have severe pain. So you stop injecting. And then what you should do now?
Sir, keep the needle in situ, sir.
Needle or cannula if you have got it.
Canalize.
Okay, then what?
And we heparinize.
So you can
Heparinize.
first dilute.
Dilute, yes, sir.
So whatever the Thiopental is there, you would try to dilute it by saline.
Align, yes, sir.
You can use diluted lignocaine.
Lignocaine, yes, sir.
You can use about 15 to 20 ml of diluted in saline, 0.5% lidocaine you can inject. That will produce immediately pain relief and also it dilutes the drug.
Drug, yes, sir.
In the meantime, you have to dilate the vessels. How do
Yes,
you
sir. Yes,
dilate
sir.
the vessels?
Sir, we can give phenoxybenzamine, sir, or
Papaverine, sir.
papaverine.
Papaverine you can
Papaverine.
use. Phenoxybenzamine may not be available because phenoxybenzamine is is oral,
Alpha.
oral only. It is not available as a
Papaverine.
Papaverine.
papaverine or phentolamine, another
Phentolamine.
alpha. But otherwise, any block you can
Sir,
brachial
brachial
plexus block
plexus
or
or stellate ganglion block we can get.
stellate ganglion block or brachial plexus block. Which brachial plexus block would be ideal?
Sir, axillary block is enough.
Axillary block with minimal, side effects or complications. So you can always use any one of these blocks. So that's how intra-arterial injection invariably you'll be asked in the exam. So you say that stop injecting further Thiopental, then dilute the drug inside the artery by giving extra amount of saline or also either 0.5% lidocaine. And then you reduce the arteriolar spasm by giving papaverine, or you can use alpha blockers like phentolamine. Then you can also go for a stellate ganglion or a axial plexus block. So these are the methods by which you can decrease the effect of Thiopental accidentally injected intra-arterially. Okay, so anything else on Thiopental sodium? We almost finished Thiopental sodium.
Sir, I have one doubt, sir.
Okay.
Sir, regarding this Robin Hood phenomena, sir.
Yeah, okay. That is another very important thing which we should have discussed. What is the Robin Hood phenomenon?
Sir,
That
from
is
area rich to the area poor.
Rob the rich and pay the poor.
Vessel poor.
No, what is Robin Hood phenomenon is rob
Sir,
the
he was a rich person, sir, and he used to give to the poor.
No, he used to rob the people, rich people, and used to pay the poor,
Poor, yes, sir.
distribute whatever he used to rob, And what is this Robin Hood phenomenon that occurs with thiopentone sodium when you are giving thiopentone sodium in patients with head injuries?
Head in-
What is this?
Sir,
Hmm.
the vessel-rich
Compartments.
No, one thing you should realize in head injured patients, the injured part will be maximally vasodilated because of the pH. Because injured part usually the pH will be reduced, so all the vessels are maximally dilated there. So thiopentone cannot constrict these vessels which are as such maximally dilated. It can only constrict the other areas where it is a normal brain is there. So those areas, once the the vasoconstriction occurs, all this blood will be pushed towards the affected area.
Okay,
So that better oxygenation will be there for the affected area,
Yes.
and the scavenging of the free radicals also will be occurring from the affected area.
Okay.
Okay.
So it is robbing from the normal
Normal.
areas, and it is pushing the oxygen into the area where
Ischemic.
there is damaged area.
Yes.
Not
Okay.
ischemic area, you said damaged.
Damaged area. Yes,
Okay.
sir.
So that's how it can produce brain protection by its Robin Hood effect.
Okay.
Okay, sir.
Mahal, that you raised this. That is one of the effects. You have understood what is Robin Hood effect?
Yes, sir. Now I understand, sir.
Yeah. What is reverse Robin Hood effect?
Sir, from damaged areas, the
Huh.
blood is transferred to the normal areas, sir.
Okay. When it can occur? Reverse Robin Hood effect. What is coronary steal?
Sir, coronary steals in.
Is it same, isn't it?
Yes,
Coronary
sir.
steal is also same.
Same,
Reverse
yes, sir.
Robin Hood effect. Wherein when you give vasodilator like isoflurane, so the area where there is ischemia, it is maximally dilated. It cannot
Yes.
dilate. So when you use isoflurane, it dilates the normal vessels. So the blood is shifted from the ischemic areas to the normal areas.
Normal areas.
So ischemic areas becomes more ischemic.
Okay.
So
Okay,
that
sir.
is what is steal phenomenon.
Steal phenomenon.
Otherwise, you call it as a reverse Robin Hood.
That's
Robin. Yes, sir.
Reverse Robin Hood. From the,
ischemic area to the other.
yeah, like, you rob the poor and then give it to the
Rich. Okay, sir.
Nowadays, that is what is happening. Poor people are becoming poorer.
Poor, yes, sir.
People are becoming,
Rich will be rich, yes, sir.
isn't it? So reverse Robin Hood effect is occurring in the society.
That's right, yes, sir.
So just to, these are some of the sudden questions that can be asked.
Yes, sir.
Yes, sir.
So if you, now Mahal said about Robin Hood phenomenon. So immediately the next question by the examiner will be what is,
Coronaries. Reverse
Reverse
Robin.
Robin.
now you understood what is reverse Robin Hood, which is can be coronary steal. It can also occur in the brain when
Yes,
you
sir.
use vasodilators, like, sodium
Hemorrhagic
nitrochloride,
shock.
sodium nitroprusside, nitroglycerin in these patients with head injury patients. So blood may be shifted from the ischemic areas to the normal areas because of vasodilatation. So you should be very careful in using these drugs in patients with traumatic brain injuries.
Okay, sir.
Okay, so shall we move on to the next? You are supposed to discuss the ketamine also you are supposed to discuss, isn't it?
Yes, sir. Ketamine etomidate, sir.
No, etomidate is yours or the next?
Sir,
Sir,
ours,
etomidate,
ketamine and
etomidate
it is ours.
actually, sir.
Okay, midazolam and
Dexmedetomidine
I
is
think I'll see, sir, whether they are there, sir.
no. Anyway, we'll not be able to discuss those things because only
Okay, sir.
15 minutes are left out.
yes.
So
Okay.
what you can do is you can ask any doubts regarding the thiopentone barbiturates and propofol.
Sir, I have another doubt, sir.
Okay.
Sir, if a general they are telling short GA, sedation, what is
Okay.
it, sir? It is there
Oh.
actually, sir, short GA and the Murray term
One
is
thing
there.
you should realize, GA is GA.
GA, yes, sir. Okay, sir.
There is nothing called as a
The
short
short
GA and
GA.
long GA.
Yes, sir.
Okay,
But
sir.
surgical procedure can be a short surgical procedure or long surgical.
Long surgical process. Okay, sir.
Because, when I passed out my MD and then went to Bellary, my first postings was in Bellary as a assistant professor. So then, I used to practice a lot.
Yes, sir.
So the first, when I went for my first case, so one very senior surgeon was there. And
Yes,
he told me that, Dr. Gurudhar, there is nothing called as short GA or long GA. General anesthesia, it is like, the person is standing on the edge of a well, and it's like pushing the person into the inside the well. From
Yes,
the edge
sir.
of the well, you are just pushing him into the well, and anybody can do this. That is what he said. Anybody can inject and then knock out the patient.
Patients,
But,
yes,
But
sir.
bringing the patient out of the well is only the
Yes, sir.
art of the anesthesiologist.
Yes, sir.
Is only the art of the anesthesiologist is bringing out the patient from the deep from the well, that is from the state of anesthesia. So that is what you have to be extremely careful, and you have to do a proper pre-anesthetic evaluation. You have to use proper safety measures for the patient, and you should be able to bring out the patient from the deep state of anesthesia.
Yes,
So
sir.
that is why anesthesia is anesthesia. It is nothing
Yes.
a short anesthesia or a long
Yeah,
anesthesia.
long.
Yes, sir.
But surgical procedure can be short or long. So
Yes, sir.
that you should always know about. Okay, somebody is, sir, when we can expect reverse Robin Hood effect? So reverse Robin Hood effect can occur with any of the vasodilators if you're using, especially in those patients with severe ischemic heart disease or in traumatic brain injury patients. So you can have this coronary steal phenomenon, and in the brain reverse Robin Hood effect can occur. So you should be cautious. Why you should know about this is you should be cautious. So it can occur whenever you use vasodilators.
Okay.
Sir, one case, sir, actually, sir.
Hmm.
They have, did arterial line have been secured, sir.
Okay.
But after which the radial pulse we were not able to feel, sir.
In brachial artery.
In brachial artery they secured artery line, sir. And
Okay.
after which we were not able to feel the radial, sir. But
Radial.
the pulse oximetry and heart rate, everything was showing, sir. It just because of the ulnar circulation which is radiate.
No, because brachial artery means brachial artery divides into ulnar artery and radial
Artery
artery.
and
radial
radial
artery,
artery, sir.
So, if at all, if there is a blockade further down, it should be for both actually, whether it is a radial artery blockade or this thing, or preferentially if the, the thrombus, if it has occurred.
Okay, sir.
So afterwards, what happened?
Sir, we were not able to feel, sir.
Radial
that is
pulse.
Radial
okay.
pulse.
No, that is okay. You must have asked for Doppler.
Yes, sir. The Doppler showed no thrombus, but there was a biphasic flow, sir. In sir, just 1 second, sir. I'll just
Now, was there any flow in the radial artery or not?
sir, just sir. I will just
Read the
read
report,
the
sir.
report, sir.
No, when it happened actually?
Sir,
2 days back.
2 days back, sir.
2 days back. Why you could not get the radial artery? Why you went in for brachial artery? Because brachial
Sir,
artery
it is around 3 mm. 3 mm is the diameter of the radial artery.
Mhm.
So we choose to go to brachial artery, sir.
Brachial artery. Okay,
Yes, sir.
okay. Mm-hmm. Now, anyway, how is the patient now?
Sir, the patient is fine, sir.
Patient
But
is
the
fine.
thing is that we are confused why we are not able to feel the radial artery just because like anything something like this happened. You are saying, no, sorry, we can accidentally maybe.
I don't think so, because afterwards, you are able to palpate the radial artery later.
No, sir.
Even now,
Not now, sir. Even now, we are not able to palpate the radial artery, sir.
before you were able to palpate before. No,
Before,
why you must have chosen brachial artery means there must have been some problem with the radial artery. He must be having a peripheral arterial disease,
Dr.
maybe.
JP,
The patient. Because otherwise you would not have chosen brachial artery, isn't it?
Right.
Because there was
Yes,
a
sir.
problem with radial artery, you went in for brachial artery.
Brachial artery.
Yes, sir.
Already there must have been some problem which might have got exacerbated because you have cannulated a proximal artery. That is what I can.
It is very small when we saw in an ultrasound, sir.
That is
We
what.
can't
That is what
secure arterial
Yeah.
line in radial, sir.
That is what the patient must have. But were you able to palpate the radial artery before? That is very important now.
Yes, sir.
If you are not able to palpate the radial artery before only, naturally you will not be able to palpate the radial artery after cannulation of the brachial.
Yes.
Yes, sir.
One of our friend took that
One of
case,
our co-PGs
Yes,
have
took
taken the
that
case,
case,
sir. So
during
So whether
discussion.
he had-
discussion.
Whether he was able to palpate the radial artery or not, first you should ask him.
Yes, sir.
Yes, sir.
So suppose if he had not palpated the radial artery, maybe he had palpated the other limb radial artery before when he was doing a pre-anesthetic evaluation, he had not palpated. You are supposed to palpate all the peripheral arteries, isn't it?
Yes, sir.
And no, you just ask whether he has palpated the particular concerned radial artery or not. So he just used his ultrasound probe to just see. Maybe he was not able to palpate. That's why he must have placed his ultrasound probe. And once he placed his ultrasound probe, there was very, very small diameter radial artery, maybe some anatomical variation of the radial artery. So that's the reason why you must have gone for brachial artery cannulation.
Yes, sir.
So afterwards, somebody else might have tried to palpate the radial artery. It was not palpable. No, that is what.
Yes, sir.
No,
The
you.
Doppler shows brachial normal flow, sir. Ulnar artery minimal flow and radial artery biphasic, sir.
Biphasic means, you should discuss with these radiology people what is happening. So that is what I feel, that there must have been some anatomical variation in the distal arteries. What is
Yes,
the
sir.
patient actually for?
Sir?
What is the patient for? What was he posted for?
Sir, Graham's procedure, sir.
Exploratory laparotomy for gastric perforation.
Gastric perforation, sir.
Gastric perforation. Was he a smoker?
Sir?
Sir, it's a female, sir. Female, sir.
Female patient.
Female
no,
patient.
Did he have any peripheral arterial disease?
So it has not been.
Yeah, that is what, it was probably an emergency. So
Emergency case, sir.
now, what
I
about
think
the
I
other
have-
arteries?
Sir, can I add something to this, sir?
Yeah,
Mukhtar here, sir. How are you, sir?
Oh, fine, Mukhtar.
Actually, this case during one of my last duties, we had this patient, sir. One lady with no comorbidities and not diagnosed with any peripheral arterial disease.
Okay.
And we initially tried, it was a exploratory laparotomy for later proceed to this one's a Graham's procedure. We
Right.
palpated the radial artery for radial artery cannulation, but then it was palpable. We were not able to secure it because the diameter of the artery was very less.
Now,
So
palpable
we tried with gel
properly. Was it properly palpable or pulse was very weak?
Pulse was very weak, sir. Patient was in sepsis and this thing, sir. It was a weak pulse. So since it was a weak pulse, we looked under the ultrasound and the diameter of the vessel was very small. So still we used a gelco and then we 20 gauge gelco, sir. We tried to cannulate, but it was unsuccessful. Then
So
later when we scanned the brachial artery, the diameter was good and then we finally cannulated the brachial artery, sir. Later, when we went for during the post-op follow-up, we found out this the radial artery was not palpable and that unilateral flow and all in our Doppler.
Yeah, because probably that you try to cannulate it.
Yes, sir.
And that also might have produced some damage to the radial artery, because small vessel and you are trying to push the cannula. So that might have also contributed to the radial artery. That is why you always we do Allen's test and all those things. Though Allen's test may not be 100% foolproof, we always look for, suppose if the radial artery is damaged and will the
flow
perfusion through the ulnar artery is enough for the hand. So always, so because you manipulated the radial artery and then you went in for brachial artery, though manipulation might have produced some damage to the radial artery. That may be the reason why you are not able to feel the pulse later. That's what I feel.
This is just the background of this thing, sir. Like,
Yeah,
yes, what
correct,
had happened.
correct.
Yeah.
So correct. Now you are very clear about this.
Yes, sir.
Only when compared to
No, it was on my duty day, sir.
Yeah,
I was
yeah.
there for the case.
Oh, correct. So you know about it. Okay.
Okay, sir.
Okay, Mukhtar, then we conclude this particular session today. Any more doubts, Mahal?
One more doubt, sir.
Okay.
Sir, if they are calling for a procedure like esophagoscopy, endoscopy, or bronchoscopy, if we are giving just fentanyl and midazolam,
Okay.
what type of anesthesia, what to term these, sir, without giving
These are
propofol?
all procedural sedation only because
Procedural sedation, sir.
naturally you are using midazolam and
Yes,
you are
sir.
using fentanyl, and also you can call it as MAC,
Okay,
Yes,
sir.
monitored anesthesia care.
Care.
These are all called as comes under monitored anesthesia. Even procedural sedation comes under monitored anesthesia care. MAC.
Yes, MAC. Yes, sir.
You call it as a MAC. You're
Sir,
not
if we give propofol to this also, it is called as
correct. Procedural sedation.
sedation. Okay,
The
sir.
MAC only, monitored
Yes.
anesthesia care.
Anesthesia care.
Yeah, you are giving some amount of anesthesia. All these are anesthetic drugs. Midazolam is an anesthetic drug. We are going to discuss about midazolam next week. And your fentanyl, definitely, I told you, combination of midazolam fentanyl can produce even induction. And if at all, if you are using propofol or not, it depends on the type of procedure and the type of patient, and whether he can tolerate with only midazolam fentanyl combination. And these are all monitored anesthesia care only.
Yes, sir.
Yeah, MAC.
Yes, sir.
With procedure. There is nothing called as conscious sedation. No, that is.
Okay, sir.
Yeah, yesterday I was telling you.
Yes, sir. Conscious.
You can't sedate the patient and you can't expect the patient to be 100% conscious.
Yes, sir.
Isn't it?
Yes, sir.
Okay.
Okay, sir.
Anything else?
No, sir. So for Thio, sir, for the hypothyroid patient, sir,
Okay.
is that the same dosage we give, or should we alter the?
No, depends on whether the hypothyroid patient is on treatment or not.
Okay, sir.
So that is very important. So once the patient is on treatment and you have done the TSH studies, TSH values are within normal limits, the same dose you give. You don't
Okay,
have
sir.
to reduce the dose or anything. So if the patient is not, treated,
Okay, sir.
he has got moderate to severe hypothyroidism, like his TSH values are more than 20. 10 to 20, you call it as mild. 20 to 50 TSH values, you call it as moderately severe.
Moderate.
Above 50, you call it as severe hypothyroidism based on TSH values. So micro international units per ml. So if patient is mild to moderate, you have to go for sleep dose. If the patient has got severe hypothyroidism, better to go for ketamine or etomidate. Don't use Thiopental or propofol. Because these patients are very, very sensitive for all sedatives, hypnotic drugs. And, very difficult. Because I still remember, I don't think we can, I can tell you. One patient was there, during those days when laparoscopy was just started. One laparoscopic surgeon used to visit Ballari every week on Sundays. And, he used to go to different nursing homes. Patients used to be already prepared there. And he used to operate from morning. He used to, come to Ballari by train. He used to come by 6 o'clock. So, and he used to start his surgeries from 7 o'clock to 9 o'clock in the night. 10 o'clock is another train for him to go to Bangalore.
Okay, sir.
So, like, I used to be the anesthetist for him. So we used to go to different nursing homes. So in one of the nursing homes, I had not done the pre-anesthetic evaluation of that particular patient. She was obese patient. She was actually posted for diagnostic laparoscopy for pain abdomen. So we went there, and then, IV cannula, everything was placed, and the patient was on the table. So I briefly took a history and examined her. I, went through the brief investigations. There were some STT wave changes in the, ECG. Then the fentanyl was not available during those days. We used to have pethidine, used to be the regular pre-medicant. What I used to do is I used to give 25 milligrams pethidine first. And then, as a pre-medicant, and during the procedure, I used to repeat another 25 milligrams. Now, what I did was I just gave 25 milligrams pethidine for her. And then, turned my back towards her and then arranging my, drugs and other things in the machine, and had just connected her to the pulse oximeter. There was only a huge pulse oximeter used to be there during those days, a single big thing. And suddenly, the pulse oximeter, there was bradycardia and, altered note. When saturation starts dropping, you can see. Now, the first thing I thought that, the probe has come out. I told one of the attendants there, "Hey, Raju, just see, the probe might have come out, you just fix it." He said, "Sir, probe is fine." Then I was alarmed. I looked at the patient had stopped breathing. Patient was not breathing, she was perspiring and the saturation was somewhere, 30, 40 saturation, and severe bradycardia. So immediately what I did was I held the mask and started ventilating her. Once I started ventilating her, the pulse rate started picking up. She had gone in for severe hypoxia, and that has produced, because of severe respiratory depression, because of just 25 milligrams pethidine.
Okay, sir.
So, they are extremely sensitive, and she did not give any history of hypothyroidism. Then what I did was I got an ECG done. First thing I thought was maybe myocardial infarction. So first thing I thought. So got an ECG done because there were no ECG monitoring during those days. Only a pulse oximetry.
Okay, sir.
ECG monitoring, ECG got recorded. ECG showed the same, some of the changes that were there before. Then I realized she must be hypothyroid. So I took the blood and sent the blood for lab investigations. In the meantime, I changed from thiopental to ketamine as the induction agent, and managed the case. I used atracurium instead of vecuronium. So I had to change rapidly because we had to go to the next nursing home. So, but I knew that pethidine will act for another, say, 2 hours, and the patient will continue to have this respiratory depression. So after that, she came out, and once I took out the tube, I knew that she is going to have the same respiratory depression. So, with these opioids, as long as you keep stimulating them, they breathe. That is one of the things of respiratory depression with opioids. You keep stimulating, you wake them up, they'll be breathing. Otherwise, they lapse into respiratory depression. So in the post-op, this thing, I told the attendants to keep on stimulating her. I waited for half an hour. She continued to have these spells of apnea. So I used to stimulate and she used to breathe. I told them. And then, I went to the next nursing home. I used to get the information of them. And also I put oxygen mask for her. She was fine. So when we got the report, the TSH was more than 100 international units.
Okay, sir.
So that's how, these hypothyroid patients are extremely sensitive to opiates and hypnotics and sedatives. You have to be extremely careful.
Okay, sir.
That is, one of the experiences I had with these.
Okay.
Okay. Any more doubts?
Both hypnotics and sedation is the same term, sir?
No, hypnosis is almost anesthesia.
Okay, sir.
Sedation is, if you have a BIS monitoring, if you are having a BIS of, say, between 70 to 90, it is sedation.
Yes, sir.
Near 70 is deep sedation.
Okay,
And 50 to 70 is anesthesia or hypnosis.
Okay, sir. Okay, sir.
Yeah, that is what is no difference. You can say sedation, hypnosis,
Okay.
mild sedation, deep sedation.
Okay, sir.
And deep anesthesia is less than 50 is very deep anesthesia.
Deep anesthesia. Okay, sir.
Because these are anesthesia depth monitors, BIS monitors, and entropy monitor.
Okay.
Okay, anyway, you can still have doubts. Anyway, we are going to have to continue ketamine,
Next week.
and midazolam and
Next
the
week.
dexmedetomidine.
Yes.
Friday.
Yes,
Yes,
sir.
sir. Sure, sir.
Okay, then.
Yes, sir.
Thank you so much.
I think the exam just finished. Students successfully, they wanted to just talk to me. I think they are there in this this thing, or you want to Mukhtar?
Sir, Mukhtar sir is here, sir. Mukhtar sir is here. Krishna
Sir,
sir is
we
here.
created a separate link for that, sir. I've shared it with you.
Okay, then I'll leave this and then join with
Yes,
that
sir.
link. Okay. Okay, then Mahal and Balaji and others. Good night.
Yes,
Thank
sir.
you so much,
Thank you,
sir.
sir.
Thank you so
sir.
much.
Yeah. Just I leave and then